EM board bombs.
Welcome to EM Board Bombs. We're back. It's nice to have the crew back in action.
Yes, Dr. Hussein's alter ego is here.
Yes.
Dr. Hussein, I'm looking at right now, has no glasses. I don't think it's Dr. Hussein.
Oh my gosh, you're right. This is, I think, the first time. I'm trying to get used to it.
Alter ego.
I know. I'm going to like a water park with my kids, and I need to
cute.
not be able to wear my normal glasses. I have to get used to wearing contacts again. I barely wear contacts.
Hey, pro tip.
Yeah.
Because I had a patient recently do this. Make sure to take your contact lens out. He left his in for 7 days.
Oh, yes. I will be.
That was not
immediately
good.
Afterwards.
That was not good.
At
He
Atlantis,
forgot that he left it in for so long that he put another contact lens on top of it.
That's terrible.
And then he came in. And have you ever seen Nickelodeon slime? That was what it looked like when I took it out of his eye.
What's really funny is we've each had like the ED patient where you go to like about to stain the eyes and you're like, are you wearing contacts? And they're like, no, I took them out. And you're like,
exactly.
No, you're wearing contacts. That is why your eyes are so injected. Every ED doc has had that happen to them.
Hilarious.
If you've been practicing long enough, you've had it happen, and they're just so dumbfounded. They're like, maybe.
The best part about this one was this guy went to an optometry clinic, and they said he had conjunctivitis.
Get out of here! Get out! No.
Yeah, I know. Kind of frightening, actually.
Oh man,
ladies and gentlemen, very scary. Very scary, ladies and gentlemen. Choose your eye doctors wisely.
Hashtag real life. Hey, we are EM board bombs.
We're not talking about eye problems today.
No, we're not. And my other topic, which was mastitis, again got pushed out because Dr.
We're never doing that.
He's like, no, let's do something else. Let's do something. We are doing something else related to pregnancy.
Yes.
I think this is kind of like a hot button topic. Or interesting topic, maybe controversial topic. I feel like we might get some emails about this with people giving their own 2 cents about this. But I think it's going to be good. It's going to be good. It's going to be great. Yeah, it's going to be great. So, hey, let's just jump into the STEM.
Let's go.
A 23-year-old patient presents to the ED with the chief complaint of shortness of breath. She states she recently traveled to Mexico and flew back last night. She complains of dyspnea on exertion, and she's having significant pleuritic chest pain. Vitals are within normal limits. EKG is reassuring. Physical exam reveals a normal cardiovascular and pulmonary exam. Extremities show bilateral lower leg swelling with more swelling on the left lower extremity. No calf tenoris to palpation. As you leave the room, she says, hey, when are you guys doing my ultrasound? I'm supposed to be 22 weeks pregnant as of today. You thought she was just a little obese, but
whoops.
Whoops.
It's a good thing you didn't say the opposite. So when do you do?
What's the next best step? Is it A, order a D-dimer? Is it B, venous Doppler of the left leg? Is it C, a VQ lung scan? Or D, CT angio of the chest?
Does C, the VQ lung scan, does that include admission to the hospital?
Yeah, we should. Hey, first, before we get into that, we got to talk about our sponsor.
Say the correct answer.
We'll tell the correct answer in a second. We got to talk to our sponsor here.
Let it marinate.
EM News. EM News.
EM News.
Go to EM News. They're pretty awesome.
News.
They've got a great reputed author. One of their many authors.
Geez.
I think Alma Matu's on there. Everyone else.
Yeah,
you're like publishing along the sides of Alma Matu. Look at you, Briggs.
What an honor.
I mean, what an honor.
You know he's my jam.
I love
that guy.
I love when my fellow colleagues come up to me and they're like, did you read Briggs's latest piece? It's quite controversial. And I'm like, I think that's the point.
Hence the title, Clinical Controversies.
Clinical Controversies, right? It's great. They love it. They love reading your stuff, Briggs. But EM News is awesome. Check it out. It's free. It's for all EM providers. You can even get like print copies sent to you if you want. If you want
for free.
Old
it's
school.
all for free.
Folks,
you know what also you should check out?
What?
EM Rapid Bombs.
Oh, EM Rapid Bombs, yes. Board time is coming up. We're starting to see more signups. EM Rapid Bombs, you get multiple new episodes delivered every month. You get custom email sent to you multiple times a week, spaced repetition learning, all that good stuff. All for less than the price of Netflix. The funny thing is our prices haven't changed. Netflix prices are like increasing like crazy. So
we are
much
not
less.
victims of inflation.
We better
We get the
or
people
worse.
what they want. Yeah,
We just give people what they want. But like,
we don't change the prices.
It's like so much cheaper than Rush and everything
my
else.
gosh.
But
So much cheaper.
I know, right?
Yeah,
We got like
450
almost 500
questions and counting.
Right? It's like almost 500 questions. Pretty much everything you know for ports. It's pretty great.
Yeah.
So emrapidbombs.supercast.com or just
Also
go
check
to
our
EM Board
website.
Bombs. Yeah, go to emboardbombs.com and you
That's
can
easier.
show
Do
notes
that.
for the links. Yeah, click on our question bank. So
You can pay
you'll
right
get that.
there.
I know the great thing is that I think we're
So
like the
flawless.
only one that has
Yeah.
a EM podcast type question bank. One of
One-click payment, one-click
one-click
sign up.
payment. It's pretty easy. Yeah. It
Yeah.
was funny. Like somebody messaged us the other day. They were just like, I basically just reserve y'all's podcast for road trips, and I just
Nice.
listen to you guys on repeat.
Just hammer mode.
Hammer mode. Hey, so the correct
awesome.
answer here is going to be what, Briggs?
Correct answer is choice B,
Mm.
venous Doppler of the left leg.
Yes.
So rehash those answer choices. Choice A was dimer, choice C was a VQ lung scan, and choice D was CTA chest. So the correct answer was choice B, venous Doppler of the left leg. Hey, so PE is pretty rare in pregnancy, thankfully. I know it's like a fear, and we always think about it.
Yeah.
But in reality, the here's the reality check here. It's rare. You want to guess how rare? Not
How
less
rare?
than 5%, not less than 2%. It's less than 0.5% of all
That's small.
pregnancies.
That's small.
Anyway, so historically, the evaluation of pregnant patients, it's challenging, right?
Yeah.
Because I have firsthand had, APPs or other clinicians come up and say, hey, what do you typically do for evaluation of pregnant patients? Because I'm kind of worried about getting a dimer. Obviously you can't use the Wells or PERC, the usual tools that we use. And obviously everyone's hesitant to do a CT scan, as they should be on a pregnant patient. So you don't want to expose patients to radiation.
Yeah.
But then we also overwork them because we don't want to miss a PE in a pregnant patient. Obviously, it'd be devastating.
Yeah. For two
and
people.
the other problem
not
is
just
some
one.
of the exactly 2 patients. As you know from our recent podcast listeners, our 2-week special on precipitous delivery. I hope Dr. Hussein enjoyed that. By the way, Marlene and I.
Quite terrifying. But continue.
Quite terrifying. It was pretty enjoyable. I thought it was very entertaining.
Yeah, but just the situations. Yes.
Yeah, it's very helpful. Don't worry, neonatal resus is coming up soon. That'll also terrify you. So, some of the signs and symptoms also overlap from a PE. Of course, the leg swelling, the ankle swelling, that's awkward. Are you short of breath? Well, I'm pregnant. Of course, I'm short of breath. So, so of course, and then the chest pain, right? They have reflux or other chest pain etiologies. So, anyway, so it's awful. So, get into the D-dimer thing here. Get into the risk scores. Dr. Hussein, wax and wane as the associate professor you are. I'd love to hear.
Yeah.
Love to hear your opinion.
So the nice thing is, when we
you get to say indubitably a lot.
This is what I'm going to say. Back in my day. So back in my day when I was a resident, I remember we didn't really have certain risk scores to use. It was just like one of those hashtag YOLO, figure it out.
We even have CT. You're going to say that too, aren't you?
Well, yeah, we had that, but it's like,
I know.
I know, right?
I love it when I was at Wake and we'd have the GOAT, Dr. O'Brien. We all know her.
Oh yeah,
would talk to me and say, when I didn't have CT, and you were like, oh gosh, you can't. Really
she would talk about those plain films, like reading those plain films. I was like, oh,
she's like, I had to do an abdominal exam. We're like, what?
What is that? Yeah. So, before it used to be just straight up, hey, you're going to be doing like a CTA or you're going to be doing a VQ scan. And we're actually going to talk about why you should be doing a CTA as opposed to a VQ scan.
Yeah, for sure.
And we'll get into that. There's controversy associated with that, some updates associated with that as well. But recently you've had these 2 scores kind of come out that have helped a lot. So you're looking in the 2018 kind of algorithm, the revised Geneva score. So again, the revised Geneva score. And a part of that algorithm is doing lower extremity ultrasounds first. If you're worried about a PE or if there are clinical signs and symptoms of a DVT, right? So I think that's the key thing there. So as opposed to in a typical patient who comes in with pleuritic chest pain, you might just jump towards a CTP study or do a dimer. Right. The difference here and that's why we wanted to ask this question the way we did, is you'd be pushing towards getting lower extremity ultrasounds. There's some data too that shows you just get bilateral lower extremity ultrasounds as well, not even like one-sided. But again, you'd be focused on.
We kept it simple to not confuse people.
Exactly. Yeah. And then if they're from there you can do CT or VQ scan, and consider doing the dimer. The years algorithm is an interesting one because that's the one which gives you different dimer thresholds and cutoffs.
Right.
And I would say that we've gotten used to different dimer thresholds and cutoffs, right? How you would think age adjusted is a big one, right? Yeah. And I actually published a PE study for COVID. We both did, Dr. Briggs, which had different, we had different, dimer thresholds listed. But dimer threshold is something that, ED providers have gotten used to. And there, the dimer threshold in the years algorithm, the D-dimer threshold is 1,000 nanograms per milliliter in patients who have no signs of DVT, have no hemoptysis, and in whom PE is not the most likely diagnosis. So that's the nice thing. So you've got these two algorithms that you can churn through. So the revised Geneva score and the years algorithm. And I use both of them when I'm trying to do some decision-making when it comes to my patients who are pregnant and evaluating them for PE. There are some pitfalls, though, associated with that. You want to get into some of the pitfalls?
Yeah, sure. So first, the years algorithm, that depends on the dimer assay. And unfortunately, in pregnancy, the dimer assay has poor specificity, probably even more poor in pregnancy. Given that it can be elevated. And in any population, you shouldn't just order this test. I see a lot of clinicians and ABPs at work and residents who will say, hey, I don't really want to scan this pregnant patient, so let me just do a dimer. And I'm like, well, careful here. Don't just do that. I know that the reflex is to not do radiation scans, and that's very noble, but you shouldn't do the opposite, which is let me put myself in a situation where I'm going to have to order a scan if it's significantly elevated for other reasons. And so don't just think that you're doing the right thing by just ordering a dimer randomly on a pregnant patient. So be very cautious and limit to the patients who you are committed to imaging if that's positive no matter what.
Right.
And the other thing is that these studies, the ones that we're kind of hinting at here, they didn't compare the performance of any type of structured risk stratification with clinical gestalt. Walking in the room, talking to the patient, just looking and saying, oh yeah, worried about a PE. And that the problem is because so few pregnant patients have PE. Yeah. In the studies that they did here, which we're not going to go into because it's a blue collar podcast, just trust us on this. The pregnant patients in these studies, when they evaluated for PE, they only had PE like 4 to 7%, single digit percents. Yeah. And that suggests that even with this risk stratification and adjusted dimer, we are way over testing for PE in pregnancy. And that should be really good news, actually, to anybody listening to this podcast. Yeah. It's good news to me when I learned about it. Yeah. Because it means that I don't have to worry about this as much as I once thought. Yeah. That this is actually a very low risk compared to the average population of people coming in and you're doing a PE workup.
And it's not infrequent that I'll get someone sent to me from urgent care or PCP and they're worried about, they're sent for like a PE study. And the nice thing is when you know some of these studies and you look at, how low, PE findings are in pregnancy overall. And again, look, I'm not talking about the patient who has a history of, DVTs, family history of early clotting disorders, or someone who had recent surgery to their lower extremities, right? We're not talking about that. No. Or the patient who comes in with one leg swollen versus the other, like we gave that example of.
Yes.
But it allows you to have shared decision-making as well, with patients. So I employ that a lot, where I'll say, look, this is why I don't think, you have a PE. Because like Dr. Briggs said, once you go down that rabbit hole of like ordering a dimer, you're committing, you're going for it. So, I do say you are going for it. And, in this patient, or not necessarily in this patient, but say you do years algorithm, you're worried about PE, you do years algorithm, you get a very high dimer. And now you have to commit to VQ scan or CTPA. Now, you're not necessarily going to be tested on VQ scan versus CTPA because this is a little bit controversial. Yes. Not really, though, I think personally. But a lot of times, folks think, okay, yeah, VQ scan for sure. We're going to do that because there's like no radiation associated with that. There actually is ionized radiation to the
A
fetus.
good amount.
Yeah, that's associated with it. The thought was that a VQ scan was favored as opposed to CTPA study because it delivers less ionizing radiation to the breast tissue, and that's sensitive during pregnancy, right? And thus, you're going to be theoretically reducing the risk of radiation-induced malignancies. But the VQ scan does have limitations. I mean, how many times do we get VQ scans and the result is indeterminate, you know? And then you're just like, oh, okay, so I guess we're going forward with the CTA study.
Or the high probability or moderate probability
right.
reporting.
It's like, what does that
so
mean,
awful.
right?
So
what does that mean? And if you look at the dosing, at least the fetal radiation dosing, let's get into that. The fetal radiation dosing for like a VQ scan, you're looking at 0.1 to 0.3 millisieverts, right? Versus a CTPA study, which is anywhere from like 0.01 to 0.66 millisieverts.
That's close.
Right. So you look at it, even on the high end, it's like double, but that amount of millisieverts of radiation is quite low at the end of the day. Right. I mean, that's barely anything. I mean, you look at like chest x-rays being like 0.1 and things like that. Right. So it's overall, quite low. So you're looking at the sensitivity for CTA for detecting PE, that's around 83 to 100%. And then the specificity is about 89 to 97%. You contrast out to the sensitivity of EQ scan, and that can just really vary, like what you said, Briggs, depending on how they interpret it and things like that. I mean, rough ranges of sensitivity are like 77 to 98%, specificity greater than 90%. But again, many times you're getting like these indeterminate results. So again, overall, your CTA is going to be more sensitive in detecting central and segmental pulmonary emboli. It's going to provide you way more detailed images as well. Whereas the VQ scan is, not necessarily reducing radiation that much kind of in the aggregate. And at the same time, potentially yielding indeterminate results. And also, it's not an easy test to perform. It is quite difficult to perform. Sometimes folks have to be admitted. And I would also argue VQ scans are not readily available at most shops. Right?
Most shops, they're not at all.
They're not, right?
I had one transferred to me yesterday from an outside hospital.
Right.
Because they needed a VQ scan for some silly reason.
Right.
We ended up canceling it.
Right, exactly, right? So anyway, so CTA is going to be preferred for higher diagnostic, accuracy, right? Hey, so let's try to bring this all together for our folks.
For sure. So why don't we just walk through kind of a typical patient?
Sure.
Let's say you're worried about a PE in a pregnant patient. The first question you should ask is there a DVT? Any signs of DVT? And if it's they have bilateral leg swelling or unilateral leg swelling, or there's some concern, there could be a DVT. Then you're going to completely forget the PE thought and just do a DVT workup. Because it doesn't matter, right? If you find a DVT, you're treating it the same way as a PE in that case.
Even if they're having pleuritic chest pain, even if they're a little bit hypoxic, right?
They're still going to be going on a DOAC most likely.
Yeah, exactly. Yeah. You are focused on the lower legs. That's a key point there.
Right. And so what you do is you're going to do a DVT ultrasound, probably both legs, as Dr. Hussein said. And if a DVT is present, you're going to go down that treatment pathway as you would. A DOAC likely and go home likely.
Right.
If you do a DVT ultrasound and it's negative, then you're going to discuss ordering a dimer. And in that case, if the dimer is less than 0.5 milligrams per liter, then you're done. No further PE work indicated, obviously. If that dimer is positive, greater than 0.5 milligrams per liter, you're going to order the CT scan of the lungs. You're not doing a VQ scan. Now, let's say, back to the beginning of this topic here, let's say you go in the room and there's absolutely no concern for DVT. Legs are completely normal, no swelling, no redness, no pain, nothing. You're going to order a dimer in that case. And this, remember, we talked about this.
And that's, you're worried about
You're committed.
You're committed to a PE and you're worried about a PE, right? They might have some other things going on. But in this case, there are no signs of a DVT at least. There's no like hemoptysis as well. Yeah.
Right. In this case, you're going to order that dimer. And then you're going to be asking about the years criteria, which is one, any hemoptysis, likely going to be a no here. It's very rare for hemoptysis to be present in PE. And the second thing you're going to ask is the PE the likely diagnosis or equally likely? And a lot of people get confused on this. I'll have residents come up to me and say, well, I don't really know how to interpret that. I'm definitely concerned about it the most. And like, okay, that's not the question. The question is, when you walked in that room, did you think this is going to be a PE? This is definitely on the top of my list. That's the question they're asking. It's not, am I concerned about a PE? Like, I don't want to miss a PE.
Sure.
It's about, that is walking out of the room thinking, number one on my list, I got to rule out a PE here.
Yep.
That is what that question is asking. If that is not the case, then your dimer cutoff is actually 1.0. So if it's less than 1.0, you're done.
You're done.
If either of those questions I just said, hemoptysis or the PE equally likely or the most likely, then your dimer cutoff is 0.5. If that's negative, of course, you're done, or positive, you're doing CTA. Yep. And hopefully that clarifies things.
Yeah, really. I mean, consider using that modified Geneva, the years algorithm as well, pregnancy adapted years algorithm as well. I think they're really useful. Understand that, be aggressive with getting those lower extremity ultrasounds as well, if there is swelling. And then lastly, really, you should be leaning towards doing a CTA PE study,
not a VQ,
versus a VQ.
Exactly right.
And understanding that, doing a VQ, getting an indeterminate result, and then ordering a CT,
stupid
PA study. It's
and admitting the patient. Again, most hospitals.
Or having to transfer them, just not.
What a mess.
It is. It ends up becoming a mess. But thankfully, I think we've got a solid body of research and even recommendations that are more in line with that as well. Right. There are certain societies that still kind of recommend VQ scans, but more and more.
But we don't care about them.
Yeah.
I'm just
more and more, I think there is a consensus forming about CTPA studies. Lastly, you should always have shared decision making with patients too.
Yeah.
Really tell them the risks, tell them what you're worried about, and see if they're worried about it. And that always helps.
Yep, exactly.
Hey, that was pretty much it. I think we hit a couple somewhat controversial things. It'll be interesting getting feedback
Tons
on
of
that.
hate mail.
Yeah, if you get hate mail, please don't send it.
We just delete it.
Send it to Dr. Briggs. Yeah, and and then that's pretty much it. Briggs, it's good to see you again. And I'll convince you to do the episode on mastitis at some point.
I'm going to be on a vacation. Get Marlena to help you with it.
And hey, guys, unfortunately, I know we usually do Reddit Corner. It's one of our people love Reddit Corner. But when Briggs and I did some research on it, nothing.
This is a serious topic.
This is a serious topic. It's a serious topic. People take it very seriously. I think can't. It's not like a rectal bleeding, which was provided
enjoyable,
just
a
wide range of hilarity. Anyways, all right, Briggs, great to see you.
You too.
Until next time, my friend.
Bye-bye.